Hello, everyone. My name is Chung Jung Mun. Just call me Moon. It's easy to remember. I'm assistant professor, but also I'm clinical psychologist by training. I study three different conditions: chronic pain, sleep disturbances, and addiction, which frequently co-occur. And today I'm gonna really focus on like the role of sleep on pain and opioid use. And before we jump into the topic, I just wanted to have one slide to briefly kind of introduce my lab, which is called Bypass Me Lab. It stands for Biobehavioral Pain, Addiction, Sleep, and Momentary Experience Lab. I know it's long, but let me just briefly tell you what we do here. So in our lab, as you can see from the top row, we actually induce pain to people in a laboratory setting with different modalities. Pressure pain using algometer, heat pain, punctate, like mechanical pain using punctate probe, and also we have people to put their hands in the cold water. These are all safe, IRB approved. But yeah, this is to understand like our individual differences and how we process our pain in our brain. But not only we do those kind of really rigorous like laboratory-based study, we also do observational study and clinical trial in like real-world setting at people's like really home environment. So we use mobile phone to kind of assess people's experiences, cognitions, and other behaviors moment to moment. And also we have people to wear wrist wearable devices to monitor their sleep and activities. We also have people to wear like more headband type of sleep EEG, where you can actually wear at home and sleep, and we can accurately monitor their sleep architecture. Not only we use those kind of wearable devices to monitor or assess people, we also use kind of wearable devices as a kind of intervention. For instance, the bottom right corner, you see it's called bright light therapy glasses, where actually it's used for improving sleep and also restoring circadian rhythm disorder. So anyway, going back to the main point, chronic pain is a really important public health issue. Why? Because approximately 1/3 of adults in the United States suffer from chronic pain, any kinds of chronic pain, and it has huge impact in our quality of life. And furthermore, the societal cost is just ridiculously high. That actual number was like more than 10 years ago, but it was $635 billion that go into management of chronic pain, which is greater than the money goes into diabetes, cardiovascular diseases, and cancer combined. Unfortunately, chronic pain is very difficult to treat. It's very difficult to eliminate. So we actually have to help people manage their pain in some ways. Nowadays, first-line treatment is really kind of using those kind of non-pharmacological approach, using like cognitive behavioral therapy, mindfulness meditation, and acceptance commitment therapy, and so on. But still, we widely use pharmacological approach, especially using opioids. Why? Especially in the United States, like this is real advertisement in 1990s. Like it was widely advertised by big pharmaceutical companies that opioids are good for treating chronic pain without really rigorous scientific evidence. And also they were saying that it was not really addictive. Guess what happened? Nowadays, like we have more than 10 million people who misuse prescription opioids. More than 40 people die every day because of the prescription opioid overdose. And if you see the line graphs on the right side, that's actually opioid overdose death rate in the United States. It's skyrocketing and it's uncontrollable right now, even though we spend a lot of money every year to dwindle that process. So it is a huge issue. So we now know that pain and opioid use go really hand in hand, but I think it is really important to find a shared risk factor that can target both problems at the same time. And I think sleep is really important shared risk factor. Why is it important? Well, first of all, according to meta-analytic evidence, the prevalence of sleep disturbance among individuals with chronic pain is extremely high. It's like about 74%. And if we actually kind of diagnose people with sleep disorders, people with chronic pain, about half of them actually have some type of sleep disorders. Most common one is, of course, insomnia disorder. It is really logical to think that, oh, I experienced pain, so I couldn't sleep. So yeah, that is true. But the opposite is also true. When you don't sleep very well, you actually will likely to increase your pain levels and also become more sensitive. And we know this through multiple really well-controlled study, and we find causal evidence that if we actually disrupt people's sleep in experimental setting, we find significant increase in pain level among individuals with chronic pain, and also they're very sensitive to painful stimuli. The interesting thing is one of the review paper found that the effects of sleep disturbance and pain is actually the magnitude is greater than pain's effect on sleep disturbances. So it's kind of counterintuitive. And I would like to, for the rest of the time, I just wanted to talk about one of the studies that I was involved. And it is really interesting. It's actually a very well-controlled study that found that sleep disruption can actually decrease the analgesic efficacy of opioids. So just to give you a brief overview of this study, we enrolled 100 adults who are healthy, and they were randomized to either getting morphine, which is typical opioids, or placebo, like saline. And all of the people actually had to go through two different sleep conditions. One is undisturbed sleep condition, where they stayed in our lab, could sleep maximum 8 hours. We didn't disturb their sleep. But their forced awakening condition, we actually woke them up every hour randomly. And they could sleep maximum 4 hours. So they did this. Each condition, you had to stay 2 nights in a row. And then we did pain assessment. So after 2 nights of whatever sleep condition that they were assigned, next morning, they actually had to put their hand in the cold water and tolerate as much as they can. We injected either morphine or saline, and then we waited for about 40 minutes for drug to fully kick in. And after that, we did another cold pressor test to see the changes. This is what we found. It's really interesting. So the graph on the left side, so the gray bar actually is about the morphine condition, and the empty bar is actually the placebo condition. What we find for the undisturbed sleep condition is what we imagine. If we give people morphine, they were able to tolerate pain far much better than the placebo condition. That makes sense. But when people went through the forced awakening sleep disruption condition, the morphine group was not really different, significantly different in terms of their pain tolerance compared to placebo condition, meaning that the analgesic efficacy of morphine was substantially reduced after people went through sleep disruptions. I think this has an important clinical implication, because if people, let's say, with chronic pain don't really sleep very well, it's likely they might need higher dose of opioids to get the optimal level of analgesic effect. And we know from the literature that the high dose or escalation of your opioid dose is an important and robust predictor of developing problematic opioid use. So I think it is important to probably target sleep disruptions among individuals with chronic pain or who even don't have chronic pain for their sleep-related issues. So I know that within a very short period of time, I talked about a lot of things, but just wanted to emphasize two things. One is that sleep serves an important role in both pain and opioid use, and we already have really good evidence-based non-pharmacological treatment for sleep disturbances, such as cognitive behavioral therapy for insomnia. We have CPAP for apnea-related issues. And I think we need to really utilize these kind of interventions to reduce not only the burden of chronic pain, but also to prevent problematic opioid use.